speaking on the back end of a conference, you've realized that everything that you're going to say was said 20 times before in the last 2 days. So if you hear the concepts that I'm going to say, I'm pretty sure 90% of them have been repeated. But nonetheless, it's always good that we overlap with each other's work and revisit these concepts. So I'm tasked today to talk about ambulatory surgery in procedural sedation. And this is my typical setup. It hasn't come out quite nicely, but this is for a long case sedation. I've got my standalone capnograph. I've got my ECG monitor and pulse oximeter. I've got my TCI pump. And Daniel, I promise you there, right on top, it hasn't come out nicely, but that's my BIS monitor. Okay, so this is my setup, my usual setup for long procedures itself. So we're going to talk about some basic concepts of sedation, some introduction, some definitions of sedations, something about safe sedation principles, drugs that we use in ambulatory surgery, what's new, and hopefully conclude and go home to watch the rugby. So without further ado, let's work through some introductions here. So ambulatory surgery is definitely growing globally, both in the terms of the kind of procedures that we do, the complexity of the procedures that we do, and as you've heard, a lot of cases are being done that we never thought we'd be able to do, like Dr. Muller's laryngeal nerve surgery, cardiac patients, etc. So it's growing, okay? The COVID era has definitely pushed towards the sedation realm outside the hospital setting. And a lot of colleagues that you've dealt with, I'm pretty sure when they could not work in theatre and move their cases to the rooms itself, have decided to stay there, assuming that their patient profile and the procedures that they can do can remain in the rooms itself. And ambulatory procedural sedation is there to facilitate the tolerance of diagnostic or therapeutic procedures that are unpleasant, painful, and sometimes both. So what is the aim of a sedation? And that's basically to alleviate anxiety, minimize pain, and maximize amnesia. And that is in a nutshell of the sedations that we do itself. So some basic definitions. I'm sure you've seen all of this stuff before. What is primary care procedural sedation? That's sedation that we do outside the operating room, and hopefully it's in a place that meets the requirements for safe sedation. Okay, that's primary care procedural sedation. Secondary care sedation occurs within a hospital where acute care after that is available. And what is the definition of ambulatory surgery? Very simple. You come in, you do your procedure, whether it's in the hospital, whether it's in the rooms, and you go home. There's no 24-hour stay, and that's the definition of ambulatory surgery. So you've seen this slide ad nauseum, all of you guys, but it's important just to visit it again. Okay, so what is sedation? It's considered to be a drug-induced continuum of decreased consciousness, which is from anxiolysis to deep sedation, decreased nociception, and all of this you need to take into account that with the increased sedation continuum, you're going to land up into cardiopulmonary compromise. And you've all seen this graph where you've got your sedation scales there, or sedation continuum rather, where you've got your unconscious and your conscious patients. And I think maybe we should start revisiting these definitions because, most of the patients aren't really conscious when we do sedations, whether you're doing moderate sedation or so. So iatrosedation is where your dentist or your surgeon sort of speaks to the patient beforehand and treats them with soft kid gloves and tells them the procedure is going to go well. That's iatrosedation, the mildest form of sedation. And we go through to the continuum where you have deep sedation and a slippery slide to general anesthesia and tracheal intubation. So, what does our surgeon want from a sedation? Okay, this might not be a sedation procedure, but you get the point. Okay, so we tend to think surgeons are strange people. Hey, we say it amongst ourselves. Hey, he's a strange chap, that guy. Because what does he want? He wants simple. He wants an on and off switch. So he's not a difficult man. He wants you to keep the patient dead for him to operate, And once he's done, he looks at you at a blank expression on his face when the last stitch is put in or the last extraction, and he asks you, why is the patient taking so long to wake up? He's just finished, and that's what he asks. So what does a surgeon wants? It's simple, an on and off switch. I recently walked into a practice. It was a dentist. It was my first time going there, and I was a bit late. I started examining my patient. It was a child. Spoke to the mom, put the child to sleep, waited. I called the dentist in, and I looked at me. I said, hi, how are you? I introduced myself. And I said to him, your patient's ready. He looked at me with disgust on his face. And I said, what's wrong? He says to me, but why isn't the patient tubed? So this is in a dental chair for a dental sedation, and he was expecting me to have the patient tubed on the chair. So I was wondering who was doing his sedations before, or maybe I should revisit my stuff and find out how I'm doing my things. Maybe I'm not doing things right. But I mean, that's just know what your surgeon wants. Secondly, what does our patients expect from a sedation? And once again, here we say, yes, hierdie patiënt is moeilik, hoor. Our patients are difficult. Are they? I don't think so, hey? Patients want one of four things. It's a menu. And it's only 4 items on the menu that they want, okay? And they might want one of these items, they might want all 4, or a combination of these 4 things. And the things that they will tell you is as follows, is when you ask a patient, what is it that you want? He'll tell you, doctor, I don't want to feel anything, nothing. So what is he saying to you? He wants something for pain. He wants analgesia. That's the first thing he'll tell you. Second thing they might tell you is, do what you want to do. I don't want to remember anything. So, what is he telling you? He wants amnesia. Okay? The third thing that they might tell you is, I'm so nervous for this procedure. I don't know what's going to happen. So they want anxiolysis. And the last thing that the patient will tell you is, and this is probably the first one that I get out of all the patients, is, I haven't slept for months. I just want to sleep. So I don't know if they came for the procedure or they've come to sleep, okay? And I often get patients coming for a repeat procedure, and I worry that maybe they're actually just coming to get sedation, okay? So they want anxiolysis, analgesia, amnesia, and sleeping, okay? So our patients aren't difficult. That's what I wanted to bring out to you guys. So what do we want? How do we as sedationists want the sedation to go about? And I think out of these 3 things, we're probably the most strangest bunch in the equation, yeah. And I'll tell you why. So we started with a sedation. Patient comes in, he's on the table or on the chair, we give him some Dormicum or whatever your drug of choice is. We turn around, do some stuff. When we look again, a patient half asleep. If we run to the patient, dramatically pull the drapes off. Are you awake? No. He's breathing, don't worry, everything's fine. And what's the first thing that we do after that? You give him more. Yes, because he's now awake, so let's get him back to sleep. And so we just give them more. And at the end of the day, I think the sweet spot lies in all these 3 elements of sedation, that you need to find the sweet spot on what the surgeon needs, what you need, and what the patient needs in ambulatory surgery, and make it a successful sedation itself. So, this slide is basically the pillars of safe sedation, ambulatory surgery, and safe sedation. I'm just going to go talk through them briefly. You've seen them before. Maybe it's been shown differently, but I'll just talk you through them again. The first pillar is your location, okay? Outside the hospital, inside the hospital. When it's outside the hospital, make sure you've got alternative arrangement if things go wrong. Not just your generator not working, not just your inverter not powering up, but if you get an adverse event with your patient, are you able to transport them to a nearby hospital? Is a place big enough so that you can move around and perform the surgery properly, or in the event of a resus, are you able to do it in this location? And it's quite difficult sometimes in your MRI suites and all those kind of things, so just keep that in the back of your mind. So the second thing is the sedation provider, which is all you guys here. And I commend you for being here and listening through all these talks. And you need to upskill yourselves. And the only way you do this is by talking outside to each other and finding how people do things, attending these congresses. And it's imperative that us as sedation providers are appraised. And we've visited this topic many times before. But appraise yourself so that you feel you're good enough to be able to provide a sedation for your patient itself. The third pillar is the operator, and that's your surgeon. Just make sure that he's also and his staff is properly trained in at least basic life support. We take it for granted that they are, but just make sure that they're there. And they understand the limitations of what a sedation is, and they understand the limitations of which patient is suitable for sedation. Okay. The fourth pillar is the procedure. So, as we said, some of your cases can range from no tissue destruction to very little tissue destruction to a little bit of moderate tissue destruction for sedation cases. Okay, so sometimes your patients are prone, sometimes they need to be lying flat on their stomachs or whatever the case may be, and not every case is suitable for a sedation, although we would like it to be, but not every case is suitable. Keep that in the back of your mind. And the last thing is, third last thing is the sedation itself. And choose your drug regime the way that you want it, whether you're going to give intranasal, intramuscular, rectally, whatever you want to do, just make a sedation plan that works for you itself, okay? The sixth pillar is the patient. Examine your patient properly. Look at the airway, because that's where you're going to get your most adverse events, is your airway. And ASA 1 patients are fit for sedation, and ASA 2 patients are fit for sedation outside the operating room. Be mindful of your sick ASA 2 patients on the day of surgery. So that is, a controlled hypertensive diabetic, for instance, that on the day presents that's not well. Sugar is a little bit abnormal, blood pressure is high. Careful, you might lead into problems there. And a little bit about aftercare. Reinhard spoke about this yesterday quite a lot. And your first place that you're going to get complications is the patient with the airway, and the second most recorded adverse events in sedation practice is early discharge of your patients. Okay, so whatever aftercare you're giving for your patients in a hospital for a general anesthetic needs to be applied to a patient going home on the same day after sedation, okay, whether it's an adult or whether it's a child itself. Okay, so drug selection for ambulatory procedural sedation. We visited this topic ad nauseum the last couple of days. So I'm just going to run briefly through some of the stuff. The ideal drug for ambulatory surgery should have a short time to onset. Simple. It should be combined with a rapid and consistent recovery profile of your drug, easily titratable within a desired range of the sedation continuum, should produce a predictable hypnotic and amnesic effect that is dose dependent, and the drug in sedative concentration should ideally be devoid of any adverse hemodynamic, respiratory, or metabolic consequences. And lastly, you should ensure that the drug that you're using has a rapid recovery profile with a quick discharge and minimal hangover effect I will tell you a joke, but my jokes aren't conducive to the audience. Okay, this one's on. So do we have ideal drugs for sedation? We come pretty close, I think, with what we have. And the drugs that we have, we'll go through a list of them now. We can do quite a lot of procedures. Well, we have been doing some magic with these kind of drugs. So yes, I do think we come very close to what I just mentioned now. And we'll go through some of the drugs now. Any questions so far? Nothing? No, unfortunately, Maury. told Daniel one last night. Don't know if he still remembers that one.
So you can tell us.
You see, he won't even say it. Okay, great. So we'll go through these drugs, and I'll slowly start off with them while we wait for it to go. And is it on?
Yeah, it's on. It's just
Okay. Okay, Darcy. So midazolam, we've heard about this quite a lot. I'm not going to bore you about the pharmacokinetics, pharmacodynamics, and all this stuff. I'll just pop up one or two things about it. So it's a fast onset drug. The problem with midazolam that we have is it's long time to peak effect. Okay, if we don't let that go by, we tend to give another dose. And once we give another dose, we might over-titrate patients. Okay, so keep that in the back of your mind. I don't like to redose my patient with dormicum, okay, or midazolam. Once I've given a dose, I don't give it again, irrespective how long the procedure is or whatever. Propofol, another magic drug that we use daily, okay. The problem with propofol, well, not really a problem, but just keep this in the back of your mind. It's narrow therapeutic index. So what that means is the levels that we use in moderate to deep sedation will definitely cause apnea or respiratory depression. So keep that in the back of your mind. The other thing is it's lipid soluble. It's made in a lipid emulsion, which can cause pain on injection, and microbial growth can occur. So there is some formulations that they're trying to work out now that's water-based, but there's no investigations done on humans yet. Okay, ketamine. Do I need to say a lot more about that? We've had 2 or 3 good lectures on ketamine. In just a pearl here, ketamine comes in different concentration vials. Just make sure you use the right one whenever you're using it, because it does happen that you might mix it. Okay, dexmedetomidine. I think it might be a little bit better than midazolam in a lot of aspects. Okay, it causes anxiolysis, it causes a little bit of analgesia, and sedates your patient itself. Transient hypertension on initial injection of the dexmedetomidine, but we don't really see big problems with it. And the advantage over midazolam is that you get little respiratory depression. Having said that, I can't do a lot of kids for very stimulating work, like dental work. I don't know if anyone has tried. I'm not brave enough to try dexmedetomidine on kids for dental work yet. Has anyone tried it? I don't think your kid will sit still. But for an MRI or a CT scan, fantastic, okay? Other drug, remifentanil, I love this drug, okay? I use it quite a lot. I don't use it outside the hospital. Our guidelines say 2 things: never bolus, which was repeated earlier today, and don't use outside the operating room. I love this drug though, it really works well, okay? Etomidate, we've also spoken quite a bit about etomidate, and I'm glad I'm not the only one that brought this up. The reason why we're using it is because of its hemodynamic stability with these kind of patients. So keep that in the back of your mind, guys. The only problem with that is the adrenal insufficiency and a little bit of increased nausea and vomiting with etomidate itself, okay? Rimimazolam, I'm sure you've heard of us speak about this lately. It's a very fast-acting drug in the benzo group like midazolam. You can reverse it though, funny enough, with flumazenil. Now, I don't know why you'd want to reverse it if it works so fast in and out, but it's definitely a drug that will be changing the way we do sedations outside the operating room. Not available yet, but keep it in the back of your heads. And another drug to mention is methoxyflurane, Vicus's favorite, okay? The green whistle, okay? The reason why I'm putting it there is because I was asked by this not too long ago. I don't use it at all, simply because it's just too much of a logistics to keep sort of methoxyflurane in my sedation bag. But keep it in the back of your head because it is coming to the fore again. I think I would use it if I had a femur fracture and I was somewhere else and there was nothing else to be given to me. I would use it, but to do a colonoscopy on methoxyflurane, I don't think we'll cut the cake there. Okay, so procedural sedation in ambulatory surgery, what's new? Just keep this in the back of your mind that whatever principles you apply for a GA goes the same for a sedation. Whether your patient's in hospital, whether your patient's at home, or whether he's going whether he's in the office-based setting and he's going home the same day, you need to apply the same principles as a general anesthetic. But having said that, there is dogma that's being challenged now. And one of them is the preoperative fasting guidelines. And Reinhard spoke about this, I think it was last year. We're still fitting to the rules of the 6 hours solid foods, 4 hours milk, and 2 hours clear fluids. But the literature does suggest that some of our patients do better if they take clear fluids up until the procedure itself. I don't know if I'm too ready to progress there yet, simply because where I came from, I've had a child regurgitate solid macaroni and cheese while doing a sedation. You go grey very quickly, okay? So I wouldn't change what I do there, but keep this in the back of your heads. Post-operative escort until the next day. So the guidelines say that when you discharge someone, make sure that there's an adult with them for 24 hours. The literature once again says, what about these patients that we give opioids as a TTO? We don't send escorts with them. There's also suggestions to be made that after full anesthetic, propofol anesthetic, a patient that's recovered after the anesthetic 1 to 2 hours after that equates to the same as a normal person having 2 pints of beer, they say. So do we really need to have an escort for 24 hours? Probably not, but it's nice to have. Deep versus awake sedation. What is deep sedation? You've lost consciousness. You need to probably support a bit of the airway itself. And awake sedation. And the thought process behind this was, specifically with colonoscopies, was that if you did a biopsy under deep sedation and the patient was still, that you would probably get a better biopsy, whatever the case may be. But there's no evidence to suggest that the outcomes are better, okay? The only thing is with awake sedation is it might take you longer to get the patient in a position to be able to perform the surgery, and it might take you longer. The sedation might take you longer itself, okay? Safety issues. Currently there's a 0 tolerance for mortality in sedation practice, okay? We should not have any mortalities in our sedation. How do we prevent this? Most definitely coming here, accrediting ourselves, monitoring our patients better, okay? I don't think SATS is maybe enough for most of our cases, okay? Consider using capnography and the likes thereof, all right? So another thing is that we will most definitely have to have a look at a reporting tool for adverse events within our society here in South Africa itself. And lastly, the progress in the automation of drug delivery sedation systems currently available. When we started off sedation, it was, as Prof said, the thumb. We used to give patients just the educated thumb dose. We've progressed to TCI pumps, and subsequently the TCI pumps are progressing to the Elefeld models and the likes thereof. And the reason for that is we accommodating the very young patient and the very old patient, the very fat patient, the very lean patient into one model. So we're progressing there. And another thing that I came across was patient-controlled sedations. So it works exactly the same as a PCA pump, pain pump. So you give a patient a device where there's a lockout time of how much propofol that they can give themselves to. I don't know how far this is going to go. There was a lecture about 6 years ago given by Dr. Kobus Low, I don't know if you guys remember him, about artificial intelligence and where our jobs are going to sit in a couple of years' time. Then he said, we still got a job. Now with chat to this and all that thing, I don't know, we're moving quite fast in some strange direction, okay? And in conclusion, propofol, midazolam, and ketamine, and remifentanil are the gold standards in procedural sedation. These drugs are being challenged by new drugs, and the combinations of these new drugs and we need to explore them and document them, okay? And there's still definitely a need to clarify basic concepts of sedation, and optimal safety should be the primary concern when we're doing sedation in the ambulatory setting. And fluit, my story is uit.